let's kind of tease through, because some of these are already in play. Some of these things we've even talked a little bit about. But
let's start with number one. What do we got?
These are
I'm
these are
excited.
huge. So we are now at the EMT level allowed to give epinephrine IM via syringe. So the previous iterations were auto-injector, auto-injector only, right? And for the longest time, just the cost prohibition. Other states are years into similar programs like this, right? Multiple years, because they recognized the cost prohibitive nature of specifying the auto-injector. I already explained why it took us a while to decouple that and strip it away. But I ultimately think this is huge, right? So we can put, for the same cost, we can put so much more life-saving epinephrine out in the world, right?
And it still goes back to Dr. Spanner's comment. If somebody in anaphylaxis dies, they die of lack of epinephrine.
Hypoepinephrinemia.
I thought he said that so well.
It's one of my favorite Dr. Spanner quotes.
Yes, I want T-shirts.
But to that point, the equipment it takes to draw up from a vial is about 100 times less than what the auto-injector costs. Auto-injector is great for the untrained individual that is going into anaphylactic shock. Yeah, you want really simple, take it out, push this button, jab into leg, hold for 10 seconds, right? Yeah. And we can teach that to any lay person. EMTs are not lay people.
Correct.
But yeah, even strip that away, how many lay people have we been on in this room that have had said auto-injector in palm of hand or sticking into finger or, right?
I had to take one lady one time with it stuck in her thumb.
Right. So again, it's still not a thing without risk. And there's been a couple of things over the years. It's like when you zoom out and look at the bigger picture, it was always weird why certain things were prohibited in scope. Like, wait a second, I can train a diabetic to
give insulin to themselves.
Give insulin, or I can trust you to take nitroglycerin home, but I have to put the handcuffs on my EMT to say you got to make a phone call first.
What's the amount of people taking weight loss injections now?
Fair point, right? Yeah. So
I can train a diabetic or anyone in their family to do a blood glucose reading, but I can't have an EMR do it. EMRs can assist, but let's expand that scope to like the basic blood glucose, and that's a life-saving intervention, right?
Correct.
I've identified the patient's hypoglycemic. Yeah. Let's intervene.
Absolutely. So the IM epinephrine, I think, is huge. I think we've already seen some positive results from that. Again, we took some steps to make that as easy as possible for our EMT brothers and sisters.
And I don't think that this should be no new news to anybody in our system for sure. We've been doing this for a year
we're just going
now,
down the changes here. Yeah. The other one here that so there was a pseudo workaround here, right, which we may or may not have paid much attention to. The metered dose inhaler or nebulized broncho-dilator administration. So Ohio does this weird nomenclature where they say patient-assisted, right? And in previous iterations, EMTs were allowed to give patient-assisted nitroglycerin. This is consistent with initial education, right? And allowed to assist with these things. But the state wisely, in my opinion, years ago, broadly stated patient assistance can mean literally with the patient's medication, or if you happen to have a bottle of nitroglycerin rolling around in your truck, or you happen to have some meter dose inhalers, or you have some breathing treatments, flying around your ambulance. If you just happen to have them, you can call and get online medical control authorization for them. This strips that part away, right? So you could now, as a medical director, give pre-authorization to your EMTs by, after an effective training package, which might be 2 slides if you've already done this, so but
quick refresher.
You sign off as a physician what the what the indications and the safety guardrails are, but we are the EMTs are now allowed to give those bronchodilators again. And I know many of our docs have long said, just give them, don't save the call. I'm going to tell you. I'm just going to tell you what I'm going to tell you on the phone right now ahead of time, right? not totally proper, but it was a patient-centric response.
It is. And honestly, I think the state board of EMS has done a good job when they're even reviewing those cases, that as long as you're doing what's in the best interest of the patient, even though it may not be following the letter of the law or letter of what
administrative
guidelines
code.
are. Yeah, they give some leeway to that if you're doing what's best for the patient.
Yeah.
And my personal thing with that is, like, if you've already been trained in your EMT class to identify a patient needs a bronchodilator,
doesn't
There you
matter.
go.
Doesn't matter the form.
Yeah.
Yeah, right. Doesn't matter the
Whether-
form.
Correct.
And that goes back to, we send patients home with
Yeah.
mini air compressors and boxes of albuterol and ipratropium, and how many cases have we come into, and they're already sucking on their own nebulizer when you get there, right?
Yeah.
So
And a good point would be my wife. I mean, she was a banker when I met her, and we had our first child, and that she had croup, and they sent us home with this machine, and I wasn't even there, and they taught my wife in the office how to use it and when to give it. It's like I came home and hey, you're doing it.
Yeah.
don't even need me.
You can count quarters and give nebs.
So then the next one starts to depart a little bit. Again, this is another EMT related change, and that is glucagon administration via intranasal or intramuscular routes for hypoglycemia. So this was a fair departure from anything that was previously established in
And that's
Ohio.
at EMT level too?
It's EMT level, yeah. So
it is, and it's a little bit different when you're talking about it, because very typically this drug needs to be reconstituted.
Yeah.
That is a new,
That is a new
as
skill
well as
set,
like
yeah.
pulling up a dose medication from a vial from an EMT level. Also reconstituting a medication those are two new skills that we're not taught at the EMT level.
Right,
so
right.
it makes a lot of sense as to why we're going to pull those out, because you really do need specific training for this. It's not like we trained you that to identify a patient needs an albuterol treatment. No, we need to train you. When does this patient need this? How are you going to prepare the medication? How do you do it, and how do you then deliver
And what patient won't benefit from it too? I mean,
Correct.
You pick up signs on malnutrition and all that, and so that's an interesting one.
Yeah, no, that, and I think
and also could be life-saving, right?
Oh yeah,
yeah.
I think that's
because
the
they
key
can't
to
get IVs.
Yeah,
So.
and I think that's the key to these last three, is making it easier, on the patient side of things for these EMTs to perform these skills. You know what I mean? Because they realize that these are important life-saving skills.
Correct, right.
So that's kind of the big picture.
Yeah, this isn't feel good stuff. This
Yeah.
is course changing.
Yeah.
This
Yeah,
is course
exactly.
changing stuff.
Exactly.
And we know some of the limitations of glucagon, and I don't want to turn this into a talk about glucagon effectiveness. But one of the things that's IM or IN in here. One of the things we regionally decided is we'd like the EMT provider to give it intramuscularly. Everybody felt more comfortable with the uptake, the absorption intramuscularly. Once we crossed the bridge on training all the EMTs to give the IM epi, to John's point, the only additional thing now is, now we have to teach you how to reconstitute, right?
Which by no means is a hard task, and like you said, that could be included in a 3-slide.
I've had, sadly,
Shouldn't
like
be a hard
5.
task.
Sadly, I've got like 5 stories about providers that have come back and either said,
I gave those.
I
only.
had 2 glucagons in my box. Only one of them wasn't dried up. Here's the dried up one. And I have another story that goes, I gave them the glucagon. What happened? Nothing. I look in their drug box.
There's still powder.
The diluent is gone. The reconstitutant is still in there.
I was going to say the only thing
I'm
I've
shocked.
seen is they put it in and then they can't draw it off. I got bubbles.
Those are two very good points as to why, honestly, I would argue that reconstituting medication is the harder one
correct.
than doing an IM injection.
Yep. No.
And probably the
Absolutely
bigger
right.
place that people are going to trip over, whether you're an EMT, paramedic, nurse, physician.
No, right. This is the one that's got a lot of stir. So much stir, in fact, we did an entire episode on it. And that is the initiation of blood or blood products. So historically, if in the paramedic scope, a paramedic was allowed to continue blood or blood products that were already established. So I guess we're assuming an interfacility transport space thing here in most cases. Now we've crossed that off to allowing for initial administration. And
I would argue that more likely in our facility, but there would be a realm that, let's say that you had a prolonged extrication at a scene,
Yeah.
complicated care,
Yeah.
you called in flight because flight has blood with them. Maybe patient arrested, they're not going to fly them, they're going to go by ground, and in that case would make a good course for blood's already been administered, but you're probably transporting the
Team
critical
as
care
well.
nurse with
Yeah.
them, but there might be an instance where you have multiple patients and you can't split up that team. The team's going to go with the more critical one, and you're going to send them one unit each way with 2 patients.
Let me present you with a scenario. We just did a MCI drill at a school, and we ended up, I think, with 18 patients, and 4 of them were bleeders. What would be the reality and the possibility of that I send a squad to the hospital with my first one, and they can come back with released units of blood to house that on scene? I mean, is that a possibility here? I mean, because at that point I would already hope, unless it's a day like today, we're not going to get flight because of weather. Maybe they're coming ground, but they're going to be a ways out.
Nothing's impossible. You bring up a good point. I think that how we've looked at it from our protocolizing this, because where you practice is an area where you're just not going to have blood automatically deployed. Where we're seeing a lot of success, and Cleveland EMS has had a huge success with it, and fantastic for them to have that blood pre-deployed. We have individually talked about we can pre-deploy blood with SWAT teams that work underneath our protocol. We have had considerations for how do we get blood to those situations, and do we have regional cars? Do we have specialty care ambulances? Do we have a UH person then respond? Do you have someone from the hospital then respond? In the immediate action now, it's going to be flight, but honestly, if they're not flying and you call for that resource, they could switch to a ground unit and you could get a ground unit there, but we'd have to set up that protocol, and honestly, the blood bank would have to be made aware that you're going to want blood on scene for that if it's not coming by critical care, because
they're going
to have to prep the blood, they're going to have to prep the cooler, they're going to have to be ready for it, and then that's not an immediately turn around, here you go. It's going to take probably about an hour from the time you say I need blood to be available to you pick up and then transport.
So I mean, that makes sense, and hopefully somebody like you's coming who's also going to establish that and maintain that. I mean, I did some, critical care and flight, we learned about how to give blood, but there is some special techniques in order to be able to administer it that you should probably look out for.
And be aware of what the transfusion reactions are.
Yeah,
and how to treat them. That's the
big
serious
one.
stuff.
The technical part of administering it is
it's like
not
any other
it's
college
not all
fluid.
that.
Technical part, no, I'm talking more or less like
Transfusion reactions, so I don't want to belabor that too much, because like I said, I think we did several pieces on blood, but that can be done. That does not negate the fact that there's still not enough blood.
Yeah.
So I guess I'll just kind of summarize the entirety of what that series was, that whole blood series was, which is if we're going to do this in EMS, we have to be part of the solution.
Absolutely.
We have to be part of the solution, not just standing here with our hands out expecting, yes, we want to save lives, we all do, the blood bank does, all your physicians do, but you also got to come with a plan to help replenish.
Correct. And we even at UH started doing sponsored blood drives because of that.
Because of that, right.
We're able to collect over 100 units of blood in 2025 through that program. We're going to be expanding that into 2026 because we can't do that unless we have that resource available. That is something that's always going to be on shortage. I would love to have an overwhelming amount of blood available for the patients who need it. And for people that are listening to this and haven't listened to the blood transfusion podcast, you absolutely should.
Check that out,
But in short, blood's going to be good for trauma patients. It's good for pregnant patients. It's good for babies. It's good for cancer patients. There's a lot of products we can pull from whole blood and make components out of that can go to help save lives. Very easily, you give a unit of blood, you can save 3 lives because we pull it out in components. So, and that's at minimum, you're saving 3 lives from one blood donation.
And I don't want to downplay what you just said. 100 units is not a lot of blood, and that's sad. Like, we need to up those numbers quite a bit. It's a good start. It's awesome that happened, but it's not a lot.
Got to bump those numbers up, son. All right, now we're going to get into some of the juicier stuff here.
Oh, it gets juicy.
It gets juicier, yeah. So this isn't quite as much, but this is so juicy, but this is again a step kind of in the right direction. So sound Doppler devices, and I know several agencies that for the longest time have had them maybe on their ambulances, and there was no procedure, there was no protocol to back up their use. Now I don't foresee using this as a daily tool, but I certainly have had like arterial occlusion cases that
would have been great.
Would have been beneficial, right?
But
I think the case use probably sticks out as patients with LVADs, right?
But again, when my wife was pregnant the first time, what did they send her home with? It's like, go get a Doppler, and then we're just sitting there playing around finding arteries and stuff, and but you could hear Sophia's heart. It took a while to find it, but even we can get trained in that. So
Not a hard thing to understand.
Not a hard thing, but from if you're talking about a pregnancy standpoint and trying to find fetal heart tones, I would not encourage mothers to go out and do that because you're going to flip yourself out if you can't find
them, and that's exactly what happened with
how many times do you even go to the doctor's office and they're trying to find it, it's hard to find with those Doppler devices. And in fact, my practice is obviously nurses are trained to do that, whether they're looking for fetal heart rates or they're trying to assess blood flow in the extremities. When they can't find it, I throw away the Doppler, audio Doppler, and I go straight to ultrasound, so I can see what I'm looking at.
But ischemic limb like that would be awesome.
So that's why I singled those two case uses out as things that would intrigue me personally.
LVAD, ischemic limbs.
Less the OB, for the same reason that you just illustrated.
You could make an argument that ischemic limb would maybe possibly change your destination choice, whether or not they've got pulses or not. LVADs, honestly, from our perspective of where we're at in northeastern Ohio, probably shouldn't. If you're anywhere close to that person's home LVAD center or home LVAD community center, so you should go there. So if I have LVADs in my county, but they're not UH LVADs. So whenever we have those patients, we're going to take them to their home LVAD center. Like, do not bring them to UH. Right. I'm going to know nothing and do nothing for you. Take them directly to their home LVAD system, so that way they'll receive them. I mean, and if you've ever seen LVAD paperwork, you have a lot of phone numbers in there and you can contact. And I can contact too as a physician, but really from a hospital, you can call them on scene. They're going to give you more information on how to manage them patients, even from the emergency department. We're on the phone with the experts within minutes.
And there's also there's a protocol for that, and it has the numbers to call. But no, that's a great point. That I've had patients that we've got a lot of LVADs for whatever reason, and if it's not an LVAD issue, maybe you'll handle it. If it's a head cold, we don't need to go downtown. But if it is anything LVAD related, take them to the LVAD specialist.
And I think we're seeing more LVADs in the community because it's gone from this is a bridge device to heart transplant. Again, I can't make more hearts. I can ask more people to donate blood. I can't ask more people to donate hearts. LVAD's more becoming a destination therapy for people. That they're going to be on LVAD for the rest of their life.
I had a lady that we transported on LVAD who was on LVAD for 20-some years.
That's amazing.
And I didn't even know that LVAD was around that long until I met her. She actually told me she was one of the initial cases at clinic. But yeah, I mean, how amazing to chronically live with an LVAD unit. And then upgrade. She had an RVAD at one point. It was like she's no longer with us, but yeah.
Well, and I mean, on that horizon is going to be
that was 20 years that she
that made it because of it.
Yes, but on the next step in that realm is going to be just mechanical hearts, implanted mechanical hearts that are just not going to be left ventricular assist devices. We haven't done it yet. It'll be there.
It'll be there. AI is probably making
technology is driving so much, right? All right, so then the next thing really gets into some of the more of these, spicy things, these exotic things, is finger thoracostomy. So, from the perspective of the failure rate of needle thoracostomy, I find this a good direction to go. Does this need to be...
I'll put you on the spot. Why do you feel needle thoracostomy is failing?
It's the diameter of the angiocaths we're using, I think, are filling. And so hopefully that when we brought it in, if it did, you have 5 or 6 going down the chest. But I feel like it's very temporary when this could be a solution to just reopen a hole. But why do you feel?
That statement is just on placement studies that I've read and failure rates is where that's coming from, right? I would tend to agree. The size of the size of the entry and location probably are both playing into, and provider choice of location. I'll use broadly.
Sure.
That is where I would.
Because the recent ones that I've seen have failed, they're just not getting the depth of penetration for
correct.
it.
And,
So
and
I
you've
think
got
it's
some right there that, I mean, they're not that long.
No.
And especially the fluffier we get.
well, I'm not even saying that. What I often see is that, I mean, that's a pretty long needle. But what I'm seeing people do is kind of just like IV placements too, right? You get that
at an
flash of
angle.
blood and you realize, oh, I'm in. Well, no, I'm getting air. You're not in all the way. Your tip is in, your metal tip, but not the catheter, right? So and we can see this on CAT scan because we leave them in when you're in the emergency department. If lungs are up on chest X-ray or I got bilateral breath sounds, I'm not necessarily placing a chest tube right away.
Yep.
If they're in there and they're decompensating, they're going to get finger thoracotomy from me and then chest tube placement in the emergency department. But I often see these; they're just not in far enough. They're sitting right above the pleural level from a catheter standpoint. So if the lung is here, it's not poking
It's right.
in through.
That's a great point. So
So
they're stopping as soon
really-
as they're getting air.
Yeah, and if you get air, throw it down there.
Yeah.
Right? It's not going to hurt anything. You should hub it. So I think that if we're talking about a pneumothorax, depth of this is not. If you're going to talk about hemothoraxes,
whole different.
yeah, that you're going to get a lot of occlusion there. And honestly, a lot of the blood that's going to be in that space is already going to be clots. It's not necessarily going to be in liquid form.
And that's not new information,
No.
right? As far as the length of the catheter being insufficient to take placement technique out of it, right? Let's say somebody goes in like this rather than like this, right? So 45 or 30 degree shallow angle, like I'm starting an IV rather than, perpendicular.
Yeah,
to
and
the
you can
chest
bounce right off the pleural cath and just go, if you're doing the second intercostal space, you can go up and just not even get into the right space.
Get in the right space. But I recall when I went to paramedic school, so we're talking circa, 90, I was the 98, 99 class, right? We were discussing that at that time, studies out of Toledo and from the medical examiner that our decompression needles weren't making it to the pleural cavity then. That was a 2-inch needle, right? And that was a 3 1/4, and that became for the longest time the most ubiquitous.
Yeah.
And everything I'm seeing today is even longer than this.
I feel like this might not be utilized if this comes to part of our training because people are going to be afraid of it. But I hear what you say is when this fails and comes into the ED, the first thing you do is this. Then you move on to a chest tube.
Yeah, finger thoracotomy is part of the chest tube placement. If you haven't done a finger thoracotomy, it's not easy to do. It's really easy to lose your track. There's also concerns of like if you've got a rib fracture there, of
Cutting yourself.
which is you do not want to have a shard of bone as you have your finger inside of a patient's chest cavity.
Yeah.
That's a big concern for us, even when we're managing these trauma patients in there, that we avoid that as much as possible because we don't want to cut ourselves and then I've got someone else's bone sticking into my finger.
100%.
You can get in, obviously we talk about when you place that about where the neurovascular bundle is. You can get into that. I just had a really bad trauma in my shop where myself, the other ER doctor, and the trauma surgeon were all in the same case. I was in the groin placing lines. The trauma doc was on my side putting a chest tube in. The other doc was putting a chest tube on her side. And after we kind of debriefed from there and I was doing some of the documentation, we had a little bit of blood output on her side because there's indications on what we do next steps based upon how much blood's in that cavity. And she's like, I might have been a little bit high and gotten into the neurovascular bundle there, so it may not have been blood inside the pleural cavity. It might have been blood from the neurovascular bundle that she just might have nicked like the vein and got a little bit of like 500 cc's of blood into the pleural cath that was leaking.
Yeah.
So, but yeah, to the point, not that it can't change outcome or save lives, but how often are we getting into these? If this needle, if I can get the right depth, can successfully needle decompress a pneumothorax, how often are we actually getting to the patients that have a massive hemothorax that's going to A, change their outcome, or B, maybe it's tamponaded enough that they're alive, that once you get that because
drain that
they'll
and let it free flow.
decompensate.
well, the indication is if you're getting 500 cc's of blood out of the chest, they need to go to the OR. And if they start to decompensate, the next step is I'm opening their chest and cross-clamping what I can, whether that's, if lucky, the vasculature of the lung. If unlucky, I'm cross-clamping the aorta.
Right.
And then they're emergently going to the OR. If I'm not doing that and I have Reboa, if anyone knows what Reboa is, we can put Reboa in to tamponade that. Honestly, probably Reboa is probably safer and better than cross-clamping the aorta, because honestly at that point
We just, and
we're getting way down into it.
without getting, just because you and I have never had this conversation, they just got Reboa, I believe, earlier this year downtown. You don't have it at Portage yet, right? Yeah,
Not
okay.
yet.
You would have experienced that at where you trained at your.
We didn't even have Reboa at that point. No.
Got it.
I think that's a big European
So-
thing still, but
It was new 10 years ago. Yeah, but at down CMC,
stop dropping those.
I know.
at our tertiary care center, they have Reboa available. But yeah, if someone comes into places where I work and they need it, we've opened chests
To clamp.
to clamp, and we have had one at least in the last 5 years where I work, and then within the last 10 years during my practice, I've seen 2 chests open. So
I like the thought of this strictly if I go back to my scenario of an MCI and I'm out of needles. This might be an option.
that's a fair case point to have it available. Yeah.